Started. Good evening, everyone. Thank you for joining the Wharton Fund annual webinar. We had hoped we could do this in person. Last year, we did a webinar and we thought by this point we'd be done with the pandemic, but we're not there yet. Our speaker tonight can give us a good sense of where we are and are we nearing the end. I know that's a subject that's on all of our minds. But before we do that, Catherine LaValle will explain some of the housekeeping issues for participating in the webinar.
Thank you, Phil. A few notes before we begin. We encourage you to share any questions you have for Dr. L. Satter in the Zoom Q&A function located at the bottom of your Zoom window. If you see a question asked by another attendee that you would particularly like answered, please give it an upvote. At the beginning of L. Satter's talk, we will be launching a poll to help frame our conversation. A window will pop up on your screen with 8 questions that we ask you to answer. You'll have a short period to read and select your answers. Once completed, please hit submit. And now I'd like to turn it over to Columbia University Professor Dr. Ralph Wharton for the introduction of our speaker.
Yes, thank you all for joining this webinar. As was mentioned earlier, we would hope to have had dinner with everyone at the Lotus Club, but we'll have to postpone it another year. At any rate, I'm particularly delighted to have my colleague on the Columbia faculty, a wonderful university professor, which is the highest academic honor at the university. Dr. Wafer Al-Satter is the University Professor of Epidemiology and Medicine at Columbia University and the Director of the Global Health Initiative at Columbia's Mailman School of Public Health. She is a world-renowned researcher and has held many international conferences. She visited 30 countries or more in terms of dealing with problems like HIV, TB, and most recently, COVID-19. She was named a John D. and Catherine T. MacArthur Fellow in 2009, and she was appointed, and she was also appointed to the National Academy of Medicine in 2009, and in 2013, she was given this highest honor at Columbia University, being a university professor. In terms of globalization has been around for a long time. There's been globalization of money and globalization of trade, but now we have the globalization of a pandemic. And there is no person in the university who knows more about it than Professor L. Satter. She's been in charge of the program in many countries, but also at the university. And She's done a superb job, and she'll give you a lot of the latest information about where we are, where we are going, and her prognosis about the future. After her talk, there will be some questions directly that Dr. Peter Shapiro will handle. He'll be the discussant and present the questions. Dr. Peter Shapiro is a graduate of Princeton and Columbia Medical School, has been chief of the consultation service for the past 5 years. He's a distinguished fellow, author of many papers, and also an expert on heart disease and heart transplants. And it's my pleasure now to give the microphone to Dr. El-Sadr, and Dr. Shapiro will follow up after her talk for about 35 minutes, and we'll have 10 or 15 minutes with questions. So it's your podium, Dr. El-Sadr. Go right ahead.
Thank you.
There'll be a little poll. The poll questions come up first. Here we go.
Yes. So maybe I'll wait a few minutes where people have the opportunity to answer the questions. Is that okay?
Yes, that's wonderful. Okay.
For anyone who's still having trouble with the poll, all you have to do is answer the questions that have popped up on your screen and then hit the submit button at the bottom. To view all 8 questions, make sure you scroll to the bottom, and all answers will remain anonymous.
Thank you very much for all your responses. I'm just going to scroll through them fast. Okay, great. Thank you very much. This is very helpful. So before I get started, I want to thank you all for the opportunity today. It's really a great honor. Since I was invited to give this lecture, I've had the opportunity to learn more about the Wharton Fund. And I have to say, I've been amazingly impressed by the breadth and depth of the many contributions that the fund has made in advancing the science, and also by the diversity of areas of support, all the way from supporting laboratory systems, as well as also supporting research studies. In addition, I think the breadth of the focus has also been very impressive, with a focus on cardiovascular disease, hypertension, mental health, maternal child health. So I applaud you for all your hard work, and also for the impact of this fund in terms of advancing our knowledge. So thank you very much for the opportunity. So let me get started. So I think I'm going to share screen, and I do hope technology works today. How does it look, Catherine?
Looks perfect.
Okay, great. So I'm going to get started, and my goal today is to provide a brief and quick update on where we're at in terms of the COVID-19 pandemic. So first of all, what is the status of the pandemic today? As of today, as of September 23rd, it's estimated there have been about 230 million confirmed cases of COVID-19 around the world, and more than 4.7 reported deaths due to COVID-19. It's also widely acknowledged that this is probably an underestimate because obviously you need to be able to test people to determine that they have COVID-19, and there often has been a paucity or a non-availability of testing in many parts of the world. What's interesting about this pandemic is where the regions of the world where it has been most prominent. So for example, you'll see here in this box on your lower left-hand corner is that to date, almost 40% of the cases of COVID-19 globally have been reported from the Americas, both North and South America, and about 30% from the European region. And you can see the contributions from other parts of the world. Now, what about the recent cases and where have they been reported from? And here you'll see in the map on your right-hand side, in the top 5 countries, in terms of largest numbers of cases reported over the past 4 weeks, have been led by the United States, followed by India, the United Kingdom, Turkey, Iran, and then Turkey. Now, what about the COVID-19 pandemic in the United States? Where are we at? And you know the numbers, I'm sure, more than 42 million reported cases thus far, and more than 681,000 reported deaths. You can see here that we've experienced several surges in terms of numbers of cases, and the most recent surge that we're experiencing now, that's largely been caused by the Delta variant, we're beginning to see a plateau in numbers of cases, if not a decrease in the numbers of cases in this latest surge. I want to point out to you that while a lot of attention has been paid to the Delta surge, actually the surge that we experienced earlier in the year, December, January, and February, was actually much more severe than the one we're experiencing with the Delta variant. Now, what about what's happening in New York City? Again, New York City has been hit hard with more than 1 million reported cases and more than 34,000 reported deaths. And you can see here in this figure on the upper right-hand corner, in the latest weeks and months, is that we also are experiencing a plateau in the surge and also the beginnings of a decrease in the numbers of cases in our city. Another metric, the measure that we use, is how much transmission is going on in New York City. And here again, we have good news because you can see there was an increase. This is citywide in this blue line, recently reported with the surge, but we're beginning to see a plateau and then also a decrease in the numbers in transmission of COVID-19 in our city. So overall, we're at this point in time, we're optimistic that we are seeing a decrease in numbers of cases, decrease in numbers of transmission. And importantly, we have not experienced with the surge an increase in numbers of hospitalizations. And this is likely to be due to the effect of vaccination. So that's really important, is that our vaccinations appear to be protecting people from getting severe COVID-19 and from getting sick and needing to be hospitalized with COVID-19. So let me move on now to another topic, and that's vaccine and how effective are our vaccines. So as you probably know, that COVID-19 can infect the virus that's called SARS-CoV-2 virus, can infect an individual, and they can cause symptoms, or they can be without any symptoms at all, just causing an infection without any symptoms. And what we know is that people can transmit the virus, whether they have symptoms or don't have symptoms. But also importantly, what I wanted to point out is that the COVID-19 vaccines that we have developed have largely been tested and examined in terms of their efficacy, their effectiveness, their benefit in terms of preventing illness, in terms of preventing actually disease, not in terms of prevention of infection alone. So what is the effect of vaccination? I think the effect that I call vaccination, COVID-19 vaccination, a game changer. And you can see this very evidently in these two maps. On the left-hand side, you'll see the numbers of cases, and this is what we call a heat map, with the darkest red meaning the places in this country where they have the largest numbers of cases. And in the lightest orange and lightest yellow are other parts of the country where there are fewer numbers of cases. And you can contrast this with vaccination in the map on your right-hand side. And you'll see that in parts of the country where we have fewest cases, we have the highest rates of vaccination. While, for example, in this part of the country where you have a lot of cases of COVID-19, these are same parts of our country where there's much less vaccination. So we are seeing now a disparity that's occurring within cities, within communities, within this country, and between countries, where parts of the world where there's higher vaccination uptake that is then associated with fewer numbers of cases, and particularly fewer hospitalizations from COVID, and particularly fewer deaths from COVID. And you can see that very clearly here. This is a line that shows on this axis here, the numbers of cases, and here the uptake of vaccines. And you can see that in parts of the country, where like New York City and Massachusetts, where we have high uptake of vaccine, these are the places in California as well. These are the states where we have the fewest numbers of cases. So what it's telling us again is vaccines work, and they're very effective at preventing acquisition of this infection. And we also have as well in other parts of the country that you see here from Seattle, for example, and you can see that the numbers of cases among people who are fully vaccinated is very low. This numbers of cases of COVID-19 per 10,000 individuals in Seattle versus the numbers amongst people, 10 times the number amongst people who are not vaccinated. So we see an effect, again, the protective effect of vaccination. And then when we want to look at the real world effectiveness of these vaccines, you'll note that here that we have evidence that shows that, for example, from amongst healthcare workers in particular, is that these vaccines that we have now, particularly the two vaccines, the two mRNA vaccines, the Pfizer vaccine and the Moderna vaccines, are highly effective for protection against symptomatic COVID-19 illness with 94% protection, which is incredibly high. And here you'll see again data that show again similarly high protection, 94% reduction in the risk of being hospitalized among adults who are 65 years and older when these vaccines are used. So overall, there's been concern about what about the Delta variant? And there's been a lot of talk about what happens with the Delta variant. And I think what's reassuring is that even amongst parts, even during the Delta variant, we do have evidence again that our vaccines work, and they work very well. With vaccination, there's a decrease, 5-fold decrease in infections with COVID-19. There's a more than 10-fold decrease in hospitalizations, and more than 10-fold decrease in terms of deaths, even with Delta, in the era of Delta. So just to summarize here, the vaccine effectiveness, and these are the different vaccines. This is the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson Janssen vaccine. And here is the vaccine effectiveness, and the higher the better. 100% effective means 100% protection. And then just focus on the red circles, and this is for hospitalizations and severe illness. And you'll see again that these vaccines are really good, again, in protection against hospitalization, severe disease, with some evidence that the protection offered by the Pfizer, BioNTech, and Moderna vaccine appear to be higher than by the Johnson & Johnson Janssen vaccine. And here are reassuring data from New York City that I think I like to point out. If you look at what's happening in New York City now, and you look at the COVID-19 cases in our city, and the surge that we've been experiencing, you'll see that the surge has been largely due to individuals who have been unvaccinated compared to those who are vaccinated. So this proves again that people who are vaccinated have much less risk of getting COVID-19, getting the infection itself. And these are more data from New York City that show the same thing. You can see the numbers of hospitalizations with COVID-19 increasing And the largest proportion are amongst people who are unvaccinated, comparing to low numbers amongst people who are vaccinated. So this is, again, reassuring data at a local level in terms of how well these vaccines can working and continue to work in protecting people. I want to point out, though, that there's a huge disparity in terms of vaccination access. And in this map of the world, it shows you here the numbers of doses per 100 persons. And the darker the green color, the higher the uptake, the higher the coverage with vaccines. And you can see that some countries in the world have doing very well with very high vaccination uptake. For example, you can see darkest green, the United States, Canada, again, many countries in Western Europe, as well as in China, and also Australia as some example. There are other examples like Israel and Turkey and Saudi Arabia and several countries in South America. But you can also see that there are huge disparities here. For example, in the continent of Africa, for example, the lightest green, obviously the access, this means that access to vaccination to these vaccines has been incredibly limited. So we have disparities that are very obvious between countries in terms of the ability to get access to vaccines. I'm going to focus now and shift to a topic that I think has been in the news a lot and talk a bit about third doses and booster doses of vaccines. So just to distinguish for you the difference between getting a third dose versus getting a booster dose of these vaccines. So I think what's by a third dose, we mean that this is given to individuals where their immune system is weak. They have some immunosuppressive condition. They're either on chemotherapy or some other underlying disease that weakens their immune system. And therefore, the initial vaccination course that they receive is unlikely to have been is likely to have been insufficient to protect them. For these individuals, the goal is to give them a third dose. On the other hand, the booster dose is a dose of the vaccine, but this is usually targeted to people who did have an initial sufficient immune response to the vaccine, but maybe that over time, they've been waning of protection over time. So we have data, and this shows us data from immune suppressed individuals, and I'm not going to go into details, but these are studies that were done amongst individuals who've received organ transplants, kidney transplant, heart transplants, lung transplants, and so on, or people on hemodialysis. And what this table essentially shows you is that when you gave these people a third dose of the vaccine, a substantial proportion of them were able to mount a response to the vaccine itself. And that's the reason why it is recommended that immune suppressed individuals should receive a third dose of vaccine. So then here are the recommendations from the CDC, is that individuals who have had the severe, moderate or severe immunocompromised or weakened immune system, that they are candidates to get the third dose. For example, individuals with cancer, transplants, as I mentioned before, as well as immunodeficiency, and also people with untreated HIV infection, for example, or people who are taking very high doses of steroids are also appropriate for getting a third dose of vaccines. What about people, again, with underlying conditions? And there are some data that tell us, because the question is, should people who have an underlying condition, should they receive a third dose should they receive a booster dose? And you can see here in this slide here is, again, this is the protection from on the left-hand side is the protection from amongst individuals who have received who have no underlying condition. And you can see very high protection, 97% and 98%, while people who have one underlying condition in pink, and these individuals with Delta, pre-Delta and with Delta, they have about 85% protection. And then again, with high blood pressure, 85% protection, and with obesity, about 90% protection. So we have evidence that even for individuals with underlying medical conditions, that even in Delta, that they appear to be highly protected against COVID-19, especially severe COVID-19 and hospitalization. So the question when it comes to boosters for this, for COVID-19 vaccine are two really. Do we need them, number one? And number two is, do they work? And what does the data tell us? The data tell us that over time, and people have been very concerned about the period here from May until July and so on, and August, that's when we've had the Delta variant. And you can see here that in terms of how well these vaccines work, and the high, this is 100% protection here, is that these vaccines here in these various studies appear to have sustained very good protection against the hospitalizations from COVID over time, even during the Delta surge. And these are again showing again here in orange are the Delta from different countries, from Canada, from Scotland, England, and Qatar. Again, data that show very high protection. This is 100%. You can see very high protection against, due to, with vaccination, even against, in the orange here, the Delta variant. There have been some data suggesting, though, that maybe amongst older individuals, there would be a decrease in vaccine. You can see the sloping down, particularly amongst people 75 years and older, that there may be a waning of immunity over time since they've been immunized, since they've been vaccinated. And again, this suggesting that there might be a subset of the population where booster vaccination may be needed. So just today, actually just about an hour before we started this webinar, the CDC came up with some recommendations for booster doses. They've been meeting for 2 days, and these are hot off the press recommendations. So the CDC is now recommending a single dose. This will be a booster dose of the Pfizer. This is, they only looked at the data from the Pfizer-BioNTech vaccine, and they're recommending a single dose, again, a third dose of the vaccine, or the booster dose of the vaccine, for individuals in the following groups who've been vaccinated at least 6 months ago. This includes adults who are 65 years or older, includes residents of long-term care facilities, and includes any adult with underlying medical conditions at any age. Okay, so let me move now to another topic that's been also of great interest, which is what we call vaccine confidence or vaccine hesitancy. So what do we know about acceptance of vaccination of COVID-19 vaccines, interest and rates? This is recent data. And you can see here that in red, darkest red are individuals who are unwilling, indicate they're unwilling to get vaccinated. In the pink are uncertain whether they want to be vaccinated. In the lighter blue, plan to get vaccinated, and darker blue, vaccinated already. And this is looking at a variety of different countries around the world. And it's important to note that vaccine hesitancy is not simply a US phenomenon. It's not also just a phenomenon that we're seeing in developed countries, in high resource countries. It's globally seen in many parts of the world. And you can see the rates here. In Russia, for example, substantial proportion are either uncertain or unwilling to get vaccinated. This is the United States as of August. And then you can see other countries, Germany, Canada, and so on. But you can also see other countries like Brazil, Mexico, India, and China. But you will see that some countries, very low proportions of the population are, again, unwilling or uncertain about vaccination, particularly in China here stands out. The other interesting thing is we look at trends over time in acceptance of vaccines. And you can see here that there's, in general, over time, who are unwilling to get vaccinated, that over time, fewer people are hesitant. So you can see these are going down, which is a good sign that more and more people are willing, less likely, more willing to get vaccinated. But you can see that we certainly experience in the United States the same thing, is that more people, a decrease in the number of people who are hesitant, but now it appears that we're plateauing at about 25% of the people who are asked as to willingness to get vaccinated. So this is a challenge, and we can talk about that during the Q&A in terms of how do we overcome hesitancy amongst individuals who are uncertain, unwilling to get vaccinated. And why are people saying that they're unwilling or uncertain about vaccination? There are many reasons, but these are the most common ones cited in one survey. About 53% cite they're worried about side effects. We're waiting to see how if it's safe. 37% indicate they don't trust vaccines, 27% don't trust the government. And then about a quarter indicate the people who were asked that they don't believe they need it. So in any case, I think, and then this one is interesting, which is my doctor has not recommended it. So that's also important to keep in mind and reminds certainly doctors and other clinical providers of the importance of discussing vaccines and the importance of vaccines. So where are we at and what are we about looking ahead and what's going to happen with this pandemic? So I think we're very fortunate at this point that we have multiple layers of protection against this virus. And many of them some of them depend on personal responsibility and others are shared responsibility. Let me start first with the shared responsibility. And in terms of shared responsibility, this includes, of course, being willing to get vaccinated. This is what we call the Swiss cheese figure. And you need all these layers to protect the person on this end from getting infected with these virus particles here. So we have the vaccine as a very important shield against infection with this virus. And of course, that is a shared responsibility because getting vaccinated is good for the individual, but it's also good for the community. It's good for the society and the people around the vaccinated individuals. Then the willingness, of course, and importance to get isolated if diagnosed with COVID or to get quarantined if a close contact, the upgrading of ventilation, and then again, limiting time in crowded conditions, again, hand hygiene, cough hygiene, and then again, and masking is a very important other means of prevention of transmission of this virus. So where are we heading? I believe that in communities like New York, like many parts of the United States, we are hopefully transitioning from a pandemic to an endemic phase of this virus. And what do I mean by endemic? This is a pandemic where there's intense transmission. All of these red particles are viral particles, intense transmission ongoing in the community. With vaccination, we're almost being divided into two types of situations. One type are community and areas of the world or countries or communities where there's little vaccination. They continue to be in a similar kind of epidemic phase with intense community transmission. I think for other parts of the world, like in New York City and other parts of this country and other countries where vaccination uptake has been better, has been good, we move into less intense community transmission. We don't eliminate the virus. We don't eradicate virus. We don't think that we're going to be able to eliminate this virus in the near future. But on the other hand, we believe that with vaccination and some of the other protective measures, we can get to an endemic phase, meaning we can decrease transmission. And most importantly, with the vaccine, what we're able to do is to prevent disease and illness and hospitalizations and deaths. And this is a great achievement to decrease transmission to a very low level and to prevent the things that worry us about COVID-19, which is the severity of illness and so on. So I'm going to end by telling you a little bit about ICAP, the center that I founded and run at Columbia University, and some of our work with COVID-19. So ICAP established about 2 decades ago here at the Columbia Mailman School of Public Health. And we work with in a lot of different countries around the world, now more than 30 countries around the world, and work in collaborations at every level of the health system with national governments, with the private sector, health departments, NGOs, community-based organizations. And our core approaches really center on 4 kinds of activities that we do. One is providing technical assistance, supporting implementation of programs, capacity building, meaning training and mentorship, and lastly, again, generation of new knowledge, doing research. And where we work, and I think, again, this map tells you where we work in many countries around the world. The countries in orange are countries where we have ICAP offices, large country teams, and then the ones in blue where we do have projects ongoing. And our areas of focus are many. as was mentioned in the introduction, we focus on HIV, tuberculosis, maternal child health, malaria, COVID, quality improvement, human resource training and mentorship, health system strengthening, and also non-communicable diseases. But what have we done to pivot to respond to COVID-19 in the countries where we work? And a lot of our work over the past year and a half has been to actually support COVID-related activities on top of the work that we're doing in these countries at the same time. So we've been involved. We also have actually, in addition to the many countries work around the world, we also have 2 research sites here in New York, one in Harlem and one in the Bronx. So we've been involved in research, vaccine and treatment research, but also in the purchasing of masks and medical equipment and supplies in the countries here in the different colors, in establishing COVID treatment centers, in helping these countries develop task forces to respond to the pandemic, developing a national surveillance system to count the numbers of cases, know exactly what's going on, developing health brigade to go in the community and teach people about COVID-19, and do a lot of training of healthcare workers and how to protect themselves from COVID-19, but also as well, how do they diagnose and manage cases. And this shows you, again, the numbers of the activities that relate to COVID-19. We've done a ton of training. As you can see, we screened over healthcare workers that we've trained, have screened over 1.5 million people for COVID-19 symptoms in 11 countries. We have developed surveillance system in 7 countries and conducted surveys on COVID in 5 countries. We are also conducting research studies, as I mentioned, and we have procured more than 320,000 supply items across 12 countries. And we're now also doing some work around the whole area of vaccine preparedness and vaccine hesitancy. And these are just some photographs to share with you some of the work regarding COVID, whether it be in training or screening of individuals, or as well laboratory work to diagnose COVID-19, and also surveys that we've been conducting in the community. So I want to end by thanking you all for your attention, and I welcome your questions. Thank you.
Thank you very much, Dr. El-Sadr. I hope you can hear me.
Yes.
Great. So there are some interesting questions that have come in from the audience, and I'll share them with you in some version of an order. There are a few questions that have to do with boosters.
Yes.
And I think I'll start with this one because I have a feeling that it applies to many members of our audience and maybe a few of our panelists as well. The question is, what's the downside of having a booster, even if you don't yet meet the CDC criteria? That is, you're not over 65, you're not immunocompromised. Is there any downside to going ahead and getting a booster shot now?
I think I always say, as we know in medicine, if there's no need to get a medication, no need to get a vaccine, there's nothing that doesn't have risks. Obviously, I mean, there's always the potential for even rare side effects and so on. So I think we always have to answer the question is there a need for getting the vaccine or need for getting the medication? That's a principle we apply overall in everything we do. I think I am confident that, and I've been involved in some of these discussions. I've also listened to the deliberations of the CDC and the vaccine and the FDA advisory group, and they're very thoughtful people, independent. They're not associated with the drug company, they're associated with CDC or FDA, that look at the evidence and they weigh the evidence. And they determine, again, whether there is a benefit and whether the benefit outweighs the risk. So that's the rationale for these recommendations. It is possible that at this point in time, an individual may not be recommended to get a booster dose, but it might be that they need it in another several months, for example. So I think, again, the timing as well as the risk benefit is something that we need to keep in mind.
Would it also be the case that the deliberations about this have addressed the issue of being able to make more vaccine available in parts of the world that have not yet had widespread vaccination?
I think the deliberations actually did not take that into account at all. They are just looking at the evidence, okay? And the evidence that was provided just in the meeting yesterday and today, they look at the evidence. They're not making any decision based on equity. They're not taking into account whether there's enough supply or not. They just look at the evidence and make a recommendation based on the evidence. But you raise an important point. I showed that map that shows the huge disparity in access to vaccination. And importance, I think I always say vaccine, that in reality, COVID anywhere is COVID everywhere. So there's the whole issue of equity and doing the right thing, but there's also the issue of self-interest. The more we can prevent transmission somewhere else, the less likely there are going to be new variants and so on. So there is a self-interest in trying to vaccinate the world as well, but that was not taken into account.
So that segues directly into another question from the audience, which was, does the persistence of a high infection rate in some countries, or to put it differently, a low vaccination rate and therefore a high vulnerability rate, create an ongoing source of danger for resurgent pandemic across the globe? That is to say, if there are sites where there's low vaccination, that allows for perhaps more mutation in the virus, and that might in turn cause a resurgence of worldwide pandemic.
Yes, absolutely. And that's why I always say there's the self-interest in getting the world vaccinated, because wherever there's transmission, the reason we get variants that arise is because the virus is being transmitted from one person to another, and as it multiplies, it makes these errors and creates new variants. And I think these variants can have serious implications. Their variants can be more transmissible, like Delta, for example. Potentially, there could be variants that can cause more severe illness. There could be variants that can evade our protective vaccines. So I think that's why it's really important for everyone to get vaccinated, because we don't want to have pockets of unvaccinated individuals, whether they be in this country or anywhere else in the world, where there's ongoing transmission and the potential for generation of new variants.
Thank you. A couple of questions about boosters that I think I'll just merge them together. One question was, is a third dose the same as a booster in terms of the amount of vaccine, or are they actually different doses? And the second question was about having an adverse reaction to the vaccination, and perhaps specifically to the booster, but I would just generalize that some more and ask, what is the significance of adverse reactions to the vaccinations at any point of this series of vaccinations?
Well, firstly, to answer your first question, is the third dose or a booster dose, they're the same. And essentially, it's the same dose that people have already received. It's exactly identical. It's just the nomenclature is different because the recipients of the vaccine are different groups of individuals. Now, in terms of your second question, which is, I forgot now.
About vaccination reactions.
About that, yeah. I think there are, and you saw some of the data I showed, that there's some people who remain hesitant, and largely because they're worried about side effects and so on. And I think I always remind people that, with vaccines, we know from experience with other vaccines, over years and years and decades of experience, is that if you're going to have a side effect from a vaccine, it usually happens close to the time of receiving the vaccination. So usually people will have either a local reaction, a pain or swelling at the site of the injection, or they may have for a couple of days fatigue or fever or rash. And then we have very rare side effects that have been reported, severe rare side effects. But even those have been reported within 2 or 3 weeks of receiving a dose of the vaccine. So I always tell people who are worried and say, oh, I want to wait to see if they're late side effects and so on. I say that that's highly unlikely with vaccines. We can see that sometimes with medicines, where you can be doing well on a medication and then years later you can develop a side effect. But most of our experience with vaccines is that the side effects tend to happen early. And we know already that there have been millions, if not billions of people who've been vaccinated around the world. And thus far, the data in terms of side effects are quite reassuring.
I've heard some people say that they were concerned because they did not have any adverse reaction after their vaccination. They wondered whether the adverse reaction like fluishness or headache or muscle aches was an indication that they were mounting a good response. And if they failed to have some symptoms after their vaccination, they worried that perhaps they did not have a good immune response. Can you comment about that? Is there anything to that?
I've heard the same thing as well, actually, Peter. No, we have no evidence that there's an association between your side effects early on and how well you're protected. And keep in mind that in the initial studies of these vaccines that included tens of thousands of individuals, and that showed fantastic protection, 95, 94% protection, only a very small proportion of people had those side effects. So this tells us that the vast majority who didn't have side effects were equally protected.
Thanks. Now, there was an article, I think, in the New York Times yesterday or today suggesting that the Moderna vaccine has a more prolonged level of effectiveness than the Pfizer vaccine. And is there any reason one of our audience would like to know to think that there is going to be a different recommendation ultimately about boosters for the Moderna shot rather than the Pfizer shot?
I don't know the answer to this, but I can tell you that when you look at the initial studies that actually were the very first studies with these two vaccines, with Pfizer and Moderna, and for Pfizer, I believe the protection was 94.1% protection. I think for Moderna, it's like 94%. They were so close to each other. So I would be cautious. I think these were the randomized, the most rigorous studies. I think a lot of the data that are accumulating now, they are usually what we call observational data, so different groups of people, different populations, followed by measuring the antibodies using different assays and so on. So I caution people not in a way to take it as a fact, as a confirmed fact that Moderna is better than Pfizer. I think they're both excellent vaccines. There may be minor differences between them. And remember that when we measure antibodies, it's only one measure of the of our immune system. There's a whole other array of protections that our immune system mounts that is not as easy to measure, while the antibodies are easy to measure. So it's hard to really say that one is significantly better than the other.
Okay, a couple more questions sort of from the international public health perspective. There were some questions about what's happened in India, where there was a tremendous surge, and now it seems like there's been a tremendous decline in the rate of infection, and also about the relationship of vaccination rate, which is pretty low in Africa, and the rate of infection in Africa, which might perhaps be a bit lower than might be expected. Could you comment?
Yes, I think it is true that obviously I showed you the data, vaccination rates in Africa are quite low. And that's the people have often wondered how come then Africa did not experience as a severe pandemic as we experience in wealthy countries in North America and in Europe and so on. And there are hypotheses. I think none of them have been proven, but I can think of several. One is that most African countries have a much younger population, and that can make a big difference because obviously younger people tend to have very mild illness with COVID-19, not to get sick, not need to be hospitalized. So they may have had, just COVID-19 without any symptoms. So we can't count them. You don't go and get tested if you're feeling perfectly well. So just having a very young population can make a huge difference. The other is congregate settings. I mean, as you remember, in our country and several developed countries like European countries and Japan and elsewhere, because of nursing homes, long-term care facilities, these are often where settings where there's huge flare-ups of hundreds and thousands of cases. And in many African countries, these don't exist, or there are very few of these long-term facilities for older individuals. And similarly, again, because people tend to not live as long, unfortunately, and as the older we get, the more we get comorbid conditions, other medical conditions. That may be another reason why there isn't the symptoms and the severity to get people to the hospital. And then lastly, people say that maybe it is because there's more outdoor life than there is indoor living. That may be also another reason for why we haven't seen as much of a flare-up. Although some countries in Africa have had severe surges of COVID-19. There was just recently, similar to what we saw in this country and many parts of the world, there was a very large surge with Delta variant in several countries in Southern Africa.
Thank you. Nobody has asked this question in the Q&A section, but I think returning to the poll, can you
Yes.
give us your thoughts about such matters as riding the subway, dining in restaurants, getting on an airplane, traveling to here or there?
Yeah, I can do so. And that's a concern I hear about all the time. I do think that we don't have evidence, thankfully, we don't have evidence of transmission or clusters of transmission on public transport like the subway or buses or airplanes. Many of you who've traveled, I have traveled recently, I take the subway frequently. And you will note if you travel now, airline travel it's amazing how many people are traveling compared to 6 months ago. But yet we have not had, as to date, any outbreaks on airplanes or based on public transportation. What the data show us is most of the transmission has occurred in social gatherings. When people come together, indoors usually, could be outdoors, but largely indoors, and they feel comfortable together. It's family, friends, and so on, and they let go their guard. And if they're unvaccinated, but could be vaccinated, and then they trust people, and then they let their guard down and are unmasked. We have evidence of transmission in gyms. We have evidence of transmission in bars. And there's also been some data on transmission in sort of religious gatherings as well. So I think that's where we have data that tell us where transmission has happened, as well as in very dense gatherings. You know, if you have, there was one outbreak in a big concert where people, masses of people coming together. So I think that's what the data show us. I do think I personally don't eat indoors in a restaurant because I don't see why I should. And I always tell people, do what makes sense. If you can eat outdoors and the weather is nice, why not? And the reason is that when you eat, you obviously have to remove the mask. But on the transport, on the subways, on the buses, on airplanes, people are masking. And despite the horror stories you hear about in the newspapers about people, battles on airplanes, I have traveled on airplanes and I find that people are actually being quite good about masking, with a few exceptions, obviously.
I think I'm going to ask you one more provocative question that's just popped up in the Q&A. Your thoughts about ivermectin and HIV medications as a treatment for COVID-19?
Yes, I've been keeping an eye on this literature because it comes up all the time. We have no evidence that ivermectin or any of the HIV medicines do anything, whether in terms of decreasing the duration of illness or in terms of preventing hospitalizations from COVID-19. No evidence at all. And unfortunately, somehow, for some reason, people are latching on to this idea that ivermectin or HIV medicines can ameliorate or COVID-19. And I think we do have, fortunately now, some medications that can do so. And so I urge people that are eligible, if they're diagnosed with COVID-19 and they're eligible, there are other treatments. There are monoclonal antibodies, for example, where we have solid evidence that these injections can actually decrease the severity of illness and prevent hospitalization. So I think we have things that have been shown to work. So there's no reason to go after things that we've shown repeatedly that they don't work.
Thank you very much, Dr. El-Sadr. I'm going to now share my own screen and make a couple of comments about sort of our local phenomenal experience. Let me just get rid of those things there. So Dr. Wharton asked me to just make a comment about instead of the global picture, what it's like from the psychiatrist's perspective with a patient. And this is what it's like, basically. If you get very sick with COVID-19, you're in an isolated ICU room. It's very, very frightening. Patients come in and they cannot breathe. Many patients, especially at the start of the pandemic, when we did not really have any idea about what would be an effective treatment, were dying with no relative at hand. We were trying to bring video screens so that people could see their loved ones from a distance. Many patients developed depression, and patients were often delirious after being sedated for some time. There's a high incidence of post-traumatic stress, and in the community, there was a substantial increase in the level of substance use. And now we're beginning to get into this phenomenon of long COVID. Nobody exactly knows what that means. We identified as important tasks for ourselves as psychiatrists that we needed to find ways to provide treatment and support for patients and families during the pandemic. And I just want to give a thanks to the Wharton Fund, because it enabled us to purchase a lot of iPads and video screens so that we could do a lot more communication even with patients in isolation, or help patients connect with their families. We also realized that it was important to support the hospital staff. All the same kinds of psychological issues that affected patients were affecting staff as well. And I'm sure you're familiar with the fact that one of our emergency room attending physicians, Dr. Breen, actually developed a severe depression and then committed suicide under the strain of caring for patients in the first phase of the pandemic. We also realized that we needed to take steps to protect our own team in order to keep ourselves available to help others. And that part of our requirement and our task was to learn about the disease and do scholarship that would help in the service of caring for others. And I'd just like to comment that we were, in fact, quite able to do a good bit of scholarship in the course of the year. We published a number of papers and made many presentations. And there's just a couple of examples of work that we did at Columbia. And how does this work happen? It happens because we have research support. And now I'm going to just give you the 1-minute pitch for the Wharton Fund.
Before you do that,
Yeah.
Peter, do you want to go ahead and share your screen?
Have I not shared my screen?
No.
Oh, my dear. Just a moment. I thought I shared my screen to begin with. I'm so sorry.
That's quite all right.
Let me back up a little. I'm not going to back up to the slides that I failed to show you. I apologize. But the Wharton Fund supports innovative research and training at the intersection of mind, brain, body, and behavior in medicine. It supports work that we do in our behavioral medicine program, the Reiner Center, and in the consultation liaison psychiatry program at Columbia. And what we've done in COVID-19 is really a very small piece of what we have been working on overall. You can see we work on topics ranging from A almost all the way to Z. We work on processes from the cell and molecular level all the way up to social determinants of health. And we have many investigators who have benefited from support from the fund. Now, one thing I'd like to especially stress to you is that the Wharton Fund is tremendously effective as a generator of research, as a research engine starter. This orange line shows you contributions to the fund over time. And you can see that cumulatively over more than 20 years now, we're somewhere over $12 million in contributions to the fund. And I need to give a shout out here to some of our particular angels, Mr. Reiner and Mr. Eisman, who have been stalwart contributors over the many years, and we thank you. But look at what happens, $12 million in contributions over the many years converts into pilot projects, seed money, research infrastructure that allows us to compete successfully for grant funding from the federal government and from private foundations. And you can see here in the blue bars that we have converted $12 million in contributions from the fund into well over $75 million in grant funding, which has enabled us to publish countless studies now and work on all these different projects. So the work that we do depends on the contributions that you make. And we think that you're getting a very good return on your investment, and we really want to thank you. So we would like to encourage you to support us, and it's easy to support us at thewhartonfund.org or by sending us a check. So thank you very much. I'm going to turn over now back to Philip Wharton.
Yes, hi. I just wanted to thank everyone for coming. We hope you found it informative. I know I did. And I guess I'll say again that we hope to have an in-person dinner next year, and we can share a bottle of wine instead of talking to our TV screens or computer screens. So thank you for coming, and please drive safely. There's yet another storm coming tonight, so be careful on the roads. Thank you very much.